But it's my great pleasure this morning to be able to introduce Dr. Kate Shipman to you. Kate is a consultant chemical pathologist at the West End of the University Hospital Sussex, and she's going to give us an update around lipid management, particularly focusing on reducing cardiovascular risk. Over to you. Thank you, Kate.
Thank you, Alison. Hi, everyone. We've got lots of slides. I'm very happy to send them, and as Alison said, please put questions in. We'll try and zip through these so we've got enough time to answer questions, and we're going to look at lipid management and cardiovascular risk reduction. So we're looking at primary and secondary prevention, some common issues involving statin intolerance and your options, a little bit about familial hypercholesterolemia, and also where the lipid specialist clinics fit in. So first of all, we're going to have a look at a patient. So we've got a 35-year-old man with no known comorbidities, and he pitches up. So we've got a primary prevention patient with his cholesterol of 5.3, which you might think, well, that's roughly fairly average. Triglycerides of 4.4. Now, so technically, we'd like to see those less than 1.7 at all times, even if you aren't fasting. We've got HDL of 0.7. And that should be greater than 1 in a man and greater than 1.2 in a woman, and an LDL of 2.6. So this pattern we call the atherogenic lipoprotein phenotype, which basically means this person is fat. So if they lose weight, the HDL will increase and the triglycerides will reduce. The problem is that this pattern is associated with increased cardiovascular risk. I've got a slide later about HDL, but basically the low HDL and the high triglycerides infer that the LDL are smaller and denser. So although this person is young, will score very low on the Q risk and has a normal cholesterol, that pattern is actually quite adverse cardiovascularly. But this person needs to lose weight and they will get the cardiovascular benefits then. Oh, someone says they can't see the slides. They're moving for me. They have moved. Marvellous. Good. So this is actually quite adverse, even though the LDL isn't that high. So Q risk. So the problem with Q risk is that the biggest factor that defines when you cross the 10% threshold is age. So this is data published in the British Journal of General Practice with a massive statistical sort of national programme done annually. We looked at cardiovascular risk 1 year. And basically, you can see that all, so men at the top, cross the 10% risk threshold by 65-ish. So South Asian ethnicities crossing earlier. And for females, everyone's crossed the line by about 70. So again, another reason why you don't need to bother doing a Q risk at 80, because no one will be under 10%. So basically, age is the major risk factor. Of the, yes/no data, type 1 diabetes is the biggest button you can tick that will change people's Q risk. But this means that it always tends to underestimate the risk in the young and overestimates the risk in the older patients, because basically age is what's bringing most people across the threshold. Even though using this, so with this, they estimated about 37% of the population will be eligible for primary prevention and secondary prevention. The 9.8 million primary prevention patients, only 3.5 million are actually already on a statin from their snapshot, and it's a very large snapshot they took. So we're really undertreating people. Of course, we can definitely argue that there may be a group of older patients with comorbidities, for example, where you're not trying to produce 20 years of extra life with statins, for example. There might be contraindications or difficulties with using statins, but it's still a very low number of our primary prevention people are actually treated. Interestingly, of the 2 million people with cardiovascular disease, 20% weren't receiving any treatment. And this was done at a time where we didn't really have any other options, so that really will be no treatment for lipids. So we're not doing very well, but as you can also see here, it's showing you the risk in the young. So purple is the ones receiving statin therapy, then it's the group who are eligible but not receiving statin, and then it's not eligible. So as you can see, when you're 75 to 84, all men and all women are eligible, but less than 50% of them are actually treated. Interesting, it's these young people here where, again, you've got an enormous number of people who are eligible but aren't treated, so that might be your diabetic population. And as we know, we're underestimating the risk in these people. These are definitely a group, but we should be working harder to make sure we're closer to 100% of these younger age groups, because you could argue more, against what we're trying to do in some of the older age groups potentially. That is really age discrimination still, but there might be other comorbidities that affect your decision making here. So, right, 35-year-old man again, no known comorbidities. There's his diagnosis. So we call this pattern atherogenic lipoprotein phenotype. And as I was saying, so low HDL, so increased risk of mortality, and so all-cause mortality hazard ratio increases for men and women as the HDL falls. Fairly linear at this point, so less than 1, nice linear drop. So you can see the women slightly higher, sort of 1.2 or so. Increased cardiovascular risk, and that's due to the formation of small, dense LDL particles rather than the reduction in HDL. Because once your HDL is normal, so between 1-ish and about 2.5-ish, the risk is flat, so you get no additional benefits from having high HDL. Therefore, HDL is not good for you, nor does it offer any protection against adverse other patterns. So a high HDL is not protective. And as you see here, as the HDL goes up, you get increasing cardiovascular risk with high HDLs. So HDL is bad for you, and therefore, when someone's got a low HDL, they need to lose weight and bring themselves to the normal range. You'll see that some people have very high HDLs, and they maybe, for example, have alcoholic liver disease, where the liver is no longer able to take up HDL, which of course is not associated with good cardiovascular health. So this guy needs to lose weight because he's not going to cross your threshold for a statin. He'll sort this problem out, reduces cardiovascular risk and reduces risk of diabetes, hypertension, gout, etc. So this one, weight loss in the first instance. Now we have a 35-year-old man with a family history of premature cardiovascular disease. And remember, so premature family history, you're talking about less than 60 in first-degree relatives and less than 50 in second-degree relatives. It has to be atherosclerotic cardiovascular disease. And though technically it's not really anything, you're not looking for people who've had, really bad type 1 diabetes, etc., and other really big risk factors. You're looking for the other thing that there may not be history of CVD, but there might be sudden death in young people, and that would be worrying. And of course, there's a big problem that people don't know what people died of. There's a lot of non-paternity and people aren't speaking to their relatives, so it can be quite difficult to establish if there is or is not good family history. However, say you've got your family history of premature cardiovascular disease in a young man, you've got high total cholesterol, 8.2, but triglycerides and HDL are completely normal, and therefore this high cholesterol must be being driven by the LDL, and indeed the LDL is high. Sorry, I was just checking. Slides are happy, everyone's moving, good. So this makes you suspicious that there's underlying genetic cholesterol problem. And it's just worth noting that familial hypercholesterolemia is subtly abnormal, and it's a pure LDL hypercholesterolemia. When you see obesity, badly controlled diabetes, etc., you can get much more significant abnormalities. So FH can be quite subtle. So according to the Simon-Broom criteria, for an adult, you need a total cholesterol greater than 7.5 or an LDL of greater than 4.9. You're either looking for tendon xanthomas, which are pathognomonics, that's thickened tendons like the Achilles tendon at the back of the heel. If you squeeze your tendon, it should be no bigger than a little finger as a rule of thumb, or evidence of those in relatives, or they actually know they've got FH with genetic mutation. Otherwise, you're using the family history of high cholesterols or cardiovascular disease. So this person would meet the criteria. Oh, it's disappeared. Try again. I'm
not sure your slides are moving on, Kate, when you move them. I think people are having to move them independently. Right. Maybe when they come back up again, we could have a little trial just to see if they move. Oh, we've got something completely different now.
Yeah.
Slides.
Oh, that's not me. Let's bomb that out. It's a different talk. You don't want that one. I don't know how that appeared. How do I? It's all going well, isn't it? So yeah, so Simon criteria. So risk is the cardiovascular disease in these patients. So we do want to detect them early.
Okay, so we're back on the front slide now, Kate, the very first slide.
Marvellous. Is it changing?
It's changing. Are you doing that?
Yes.
Ah, perfect. Then it may be that it's working now and that was a blessing in disguise.
Marvellous. Reset. Good. Okay, good.
Let's try.
Is everyone happy now? Give me a shout if it's going wrong. So basically in familial hypercholesterol, you get a high cholesterol from birth. What we should have is almost no cholesterol at birth, which does creep up with age. A bigger spike in women postmenopausally, which can be quite confusing. But effectively, it should be low. And actually, if you look at hunter-gatherer tribes and other animals, LDL should be considerably lower than it is. So the LDLs that we are used to seeing is actually abnormal. Normal LDL is much lower. So the LDL receptor is only able to function between the values of 0.6 and 1.8, which would give you a total cholesterol at maximum of 3. So total cholesterol less than 3, LDLs less than 2 are normal, not low. That's actually normal. So most of us have genetic mutations that push them up, and very severe genetic mutations are called familial hypercholesterolemia. We like to pick it up because you can obliterate the increased cardiovascular disease by treating people early. So in children, for example, here, they're nice and safe. So this was children and siblings of familial hypercholesterolemia. So they're unaffected siblings taking statins, and the only significant p-value is for significantly raised CK. But as you can see, the familial hypercholesterolemia children on statins had no problems. It was their siblings who had raised CKs, and that's probably because 2 children fell off a bicycle or had a cold prior to their blood test. So there are no problems. Children have tolerated them beautifully, and there have been many further studies showing that. And with that, you see here, if you treat the adults as adults with familial hypercholesterolemia, they start dying in their 20s. Now we've started treating them between the ages of 6 to 8 years old, definitely by the age of 10, 100% of those FH children are still alive. So if you wait until they're adults, it's too late to get them back to the population risk. Not that you can't give them benefit. And as there are more than 2,000 mutations, there's a huge phenotypic variety. So you'll get some much severer phenotypes and much milder phenotypes. But basically the party line is because there are more than 100 cardiac risk factors, and this is only one problem. If you find FH, you treat them young, no questions asked, basically. And this way you should hopefully guarantee that you're obliterating the risk associated with familial hypercholesterolemia. It's also worth noting that when you're looking at relatives, you don't use the Simon Boo criteria as they're written, you use the STAR charts after Mr. Starr. They're found in the back of the CG71, the NICE guidelines, or from this paper here. And it's basically trying to take into account the age and sex difference in cholesterol. So when you're looking at relatives, you're using much lower values after you've found the index case. And a lot of this, we did a lot of this historically because genetics weren't able to pick up all the mutations, and they're very expensive. Now they're much more likely to find the cases, and now free for us because they're commissioned centrally. So you could say we should be less careful. We don't need to, I mean, we should remain careful, but we do, genetics is so much easier to access that a lot of staring at this and deciding if they have or haven't got FH based on these charts becomes slightly more historic. But they are interesting to see if you're looking to see how abnormal you think someone's cholesterol actually is. We've got the next case, so 35-year-old, so no, same one, sorry. So this is familial hypercholesterolemia. Just careful though, because you've got your postmenopausal rises in women. Polygenic is more common than familial hypercholesterolemia, but in these guys you'd expect more normal cholesterols earlier in life. It's become worse more recently, and much less history of any cardiovascular disease. And also hypothyroidism is a nice cause of hypercholesterolemia, and if you give them thyroxine it will come back down. Also hypothyroidism, you get rhabdomyolysis, so if you give them a statin they will get muscle pains, and then it makes it look like they can't take statins, and it's got nothing to do with statins. Nephrotic syndrome should be much more obvious clinically, so harder to miss, but both of those can cause a pure hypercholesterolemia, so just don't miss those. Right, another case, 35-year-old man, no known comorbidities. So here you can see really quite a significant hypertriglyceridemia, and this is interfering with our measurement of HDL, and LDL is calculated only if the triglycerides are less than 4.5, so we can't do the maths if the trigs are this high. So though this looks really abnormal, this is almost always secondary. So we're talking about diabetes, alcohol, obesity. This, therefore, should be fixed by sorting out the diabetes, the alcohol or obesity, or the liver disease. Okay, sometimes that might not be so easy, but you're not looking for genetic causes so much in these cases. It's just perhaps worth thinking about the effect, basically, of lifestyle modification, which is basically extraordinary, particularly if it's something you can reverse. But Mendelian randomization means that you take the placebo groups from randomized control trials and you see what the effect of just good genes and lifestyle is on variation in your factors without giving the drugs. So for every 1 millimole reduction in LDL and every 10 millimeters of mercury reduction in systolic blood pressure, there's an 86% and an 84% reduction of major vascular events and CHD mortality, which is enormous. So if you've got good genes and good lifestyle and all these things are perfect, absolutely amazing in regards to the difference in cardiovascular disease risk you have than someone with higher levels. Therefore, if you can get these things down with lifestyle, you will get the same potency of cardiovascular disease prevention as you will with drugs. So basically your party line is we don't care how you get it down, everything should be lower. So in people with secondary dyslipidemias, where it's obesity or alcohol, you don't need to give them drugs if they can stop it themselves. For the genetic hypercholesterolemias, you will need to give drugs to do this because they won't be able to do it with diet. But being fitter and trimmer will give them additional cardiovascular benefit. But if you're fit and then you start running marathons, you don't really get any additional cardiovascular benefit. The biggest benefit comes from doing nothing to doing something. That's quite potent. Doing lots doesn't help anyone anymore. So this guy, you're looking for alcohol, poorly controlled diabetes, obesity, liver disease. Of course, if you give this person drugs and it's alcohol, you're not going to see any significant changes. It doesn't mean that you won't get cardiovascular risk reduction with your statin, for example, but you're not going to see much of a biochemical effect. But as long as you know that and as you know why you're treating the statin and that you're not going to have effect on the numbers, that's fine. So little practical point here. So what sort of blood tests do you need to do? Use an ease, again, because we're starting drugs, but also for nephrotic syndrome, thyroid functions to make sure you haven't missed hypothyroidism, liver for your liver disease, and also for the possibility that statins cause a transaminitis, which is actually exceedingly rare. There's only really case reports where they suggest it might be the statins, but that's the same with almost every drug, so it's not a big problem. But remember, these are the group who often have obesity and diabetes, so that's why often their LFTs are abnormal, because they've got underlying non-alcoholic steatohepatitis, for example. HbA1c, because it's a cardiac risk factor, but it also might be causative of abnormal LFTs. CK is debatable, so nice say no, because actual rhabdomyolysis is so extremely rare. I find I do quite a lot of it in clinic because I've got a population enriched for side effects, but technically you shouldn't need to do it. And if someone presents with side effects, you can do a CK there. I must say that we have picked up some underlying muscle diseases in people who've then presented with cardiovascular disease. So if you've got sore muscles, it doesn't mean that it's a statin. There could be real underlying pathology, especially in your older groups where they may have things like polymyalgia rheumatica. So you may do a little bit of this, but generally that shouldn't be standard. In regards to fasting or not, it makes a tiny amount of difference to the values. So you don't need to be fasting. Plus, if someone has a postprandial hypertriglyceridemia, we want to know about it. Therefore, a stressed sample post-meal is better for you to pick up those with increased cardiovascular risk, because triglycerides do produce cardiovascular disease. So triglycerides, so they say measure it once. I think we give you a full panel, so you can't just have a cholesterol alone, but it is useful to get a full panel like that. First patient with the atherogenic lipoprotein phenotype, the cholesterol looked normal, but the rest of it looked abnormal. So it's better to get a full profile. And so some people say you can do non-fasting as long as it's less than 2, but actually if it's high, I also think there's an argument for doing non-fasting because you want to know if the obesity is actually getting better and you want to stress them and compare like with like. So, new patient, 62-year-old man, post-ischemic stroke. He's on atorvastatin 80 milligrams and ezetimibe 10 milligrams. Here's his lipid profile. What would we do next? So there's various questions here, but effectively what we've shown definitively is that the lower the LDL, the better, and that's really down to an LDL of 0. What can we do? So PCSK9 inhibitors we can add for secondary prevention. So remember this guy's LDL was too low, so it's 2.65. So for someone with one stroke, so no genetic diagnosis, one cardiovascular event, his LDL would have to be greater than 4 to be eligible for the antibodies to PCSK9, known as the PCSK9 inhibitors, which are alirocumab or evolocumab, which are once every 2 weeks injections. If he'd had 2 strokes or a stroke and a heart attack, for example, his LDL would only need to be above 3.5. And as you can see, that's really quite a high threshold, which therefore limits the use of these drugs in a lot of people where we would really like to treat them. In these trials, they showed reduction in cardiovascular disease down to LDLs of 0. So they do work at the lower limits. For FH, so familial hypercholesterolemia, you can treat for primary prevention if the LDL remains above 5, so the total cholesterol will be above 7. Or the LDL greater than 3.5 if they've had cardiovascular disease, so one event. And this is irrespective of what drugs they're on. So you have to have tried the statins and the ezetimibe first, so you can't just elect to have a PCSK9 instead. But if they've tried and they don't get on with them, then you can proceed to these drugs. This guy, however, LDL is too low. So if we're looking at PCSK9, so this is how PCSK9 inhibitors work. This is PCSK9, it circulates. So there's your LDL receptor on cells. It can either bind your LDL particle or it can bind PCSK9. So there you've got your LDL receptor of an LDL and your LDL receptor of PCSK9. As this vesicle becomes intracellular, the LDL receptors bound to PCSK9, first of all, don't take up LDL. But second of all, this sends the LDL receptor to the lysosome to be destroyed. So it's basically a way of destroying your LDL receptors. Whereas if it just takes up LDL, the cholesterol is deposited intracellularly and the LDL receptor goes back to the cell membrane and can take up another LDL receptor. So the antibodies clear PCSK9 from the circulation, and the new drug, inclisiran, basically blocks its translation into protein intracellular because it's a RNA type technology. So both are acting on PCSK9. So I don't know if anyone heard, Alice and I were chatting just before we started. Inclisiran has a nice tag, which means we're obliged to deliver it. And the eligibility criteria is secondary prevention of an LDL greater than 2.6. So this patient with his 2 strokes and with a stroke and his LDL of 2.65 would meet the criteria here. So again, they need to have tried the usual stuff. It doesn't matter if they are or are not, do not remain on it. And they have to have some sort of vascular disease. So he would now meet the criteria for a different PCSK9 agent, inclisiran. So though it's gone green, I don't know how many of you will be prescribing it soon because it's once every 6-month injection. So we're going to have to organise how that occurs in the community. The funding has been organised, but it has to be basically provided in primary care because it's at least 10-fold the cost to prescribe it in secondary care. So NICE and the government are definitely pushing for it to be done in primary care, which is very exciting because it technically will give enormous access for the patients, but is also quite an interesting decision because it will need some tweaks and service development to try and get that running. But as Alice was saying, we've got it, it's green on the formula here. So actually from now on, you can start prescribing it, hopefully in the next couple of weeks across the whole region. Whether actually anything will happen, I'm not sure. So technically you've got that option now. Another option, which got its nice tag slightly earlier, is bempedoic acid. So bempedoic acid can be used for primary or secondary prevention. But it's basically if someone isn't at target, it doesn't actually stipulate what the targets are, which gives you quite a lot of flexibility to decide what your target is. And you can go for a nice low one, which are in, they were published in multiple different journals, much lower targets. So basically, though, for this one, they have to be on ezetimibe, and the statins can't be high intensity. Again, there's a bit of debate about how it's all wording. The wording was very confusing. So you'll see a bit of variation about how that's been interpreted around the country. But here we're going, as long as they're on a dose less than atorva 20 or less than Rasuva 10, or on any other statin, they can have it as long as they're on ezetimibe. Because simvastatin 80 is the only other drug that would give you more than a 40% reduction in LDL, and no one should be using that. And Rasuva 20 and atorva 20 and Rasuva 10 are the only other drugs that give you more than a 40% reduction in LDL. So as long as they're on a dose lower than that or a different statin and on ezetimibe, they can have bempedoic acid for either primary or secondary prevention, as long as they are not treated well enough. They haven't reached the target. Interestingly, the fixed dose combination is the same price as the drug alone. So you get the ezetimibe for free in the fixed dose combination. So again, slightly unusually, the fixed dose combination is being promoted rather than prescribing both separately. Bempedoic acid inhibits cholesterol synthesis just like statins do. So citrate to cholesterol, HMG CoA reductase is inhibited by statins. Bempedoic acid, a couple of steps earlier at ATP citrate lyase, but it's a prodrug, so it's only activated in the liver, so it does not inhibit cholesterol synthesis in any of the other peripheral tissues, including muscle, and therefore there should be no muscle side effects. It's about 17 to 28% reduction. So with ezetimibe, it becomes more effective. The only other issue is it blocks uric acid secretion, so urates go up. So you might want to be a bit cautious in someone with lots of gout. It's not particularly significant numbers in the trials. Why do we want to escalate this patient? So we've got, say, a 72-year-old on atorvastatin 20. He's been on it for more than 10 years post a TIA, but he wants to stop it because he's read that there might be muscle problems. So he hasn't got muscle problems, but he's decided that he doesn't really want statins. Are we trying to force people to stay on? Yes, we are. So the data here, so cumulative mortality, and this is cardiac mortality, for people who stop statins, so this is an MI study, you can see a threefold increase in mortality and a fourfold increase in cardiac mortality by stopping the statins. Statins, of course, have enormous quantities of excellent data about how effective they are. So even though we've got all these new drugs, we really do want to use statins as our first drug. Then we add in our ezetimibe. Bempedoic acid and inclisiran have no outcome data yet. So we know they reduce LDL, but not necessarily cardiac disease, cardiovascular disease. Our hypothesis is, and it has been proven time and time again, that LDL reduction does reduce cardiovascular disease. And with PCSK9 inhibitors, we know that LDL reduction through PCSK9 reduction does prevent cardiovascular disease. So there's no reason to think that inclisiran wouldn't, or that bempedoic acid wouldn't. But statins still remain the mainstay. Big time. So we love statins, keep using those. This is some nice data from the WASCOP study. So this is pravastatin. It was an early primary prevention study. So pravastatin, as I'm sure you remember, is a weak statin. So these chaps in Glasgow with really horrific cholesterols took basically pravastatin versus placebo for 4 years. Beautifully demonstrated reduction in cardiovascular disease over 4 years. And it's one of the really good trials that led to the use of statins for primary prevention. These guys have now been found 20 years later, and their cardiovascular death has been reduced by 25%. And that's 20 years later from 4 years of a really weak statin. It's 20 years ago. Phenomenal. So good statin use or good cholesterol reduction for long periods of people's life will give them extraordinary legacy benefits. So yes to statins, early, nice and aggressive, but if you're stopping them in 80-year-olds because they have other problems, you will not undo the benefit that you've created by starting these drugs. It is impossible really for anyone to live long enough if they've had 20 years of good statin treatment in the middle of their life, for example. So they're never going to live long enough to get back to risk they would have been without the statins. So we love statins still. So next case, 62-year-old is on a Torva 40 post small ischemic stroke. What are you going to do? So what next? Are we doing ezetimibe? What are we doing? So lots of things to think about. So statin doubling, yes, you could definitely increase his statin. So it's just worth remembering that for every increase, the most effective dose is the first dose. You know, it's roughly 5%, so 6% with each doubling. So it's a small increase, but all reductions cause a reduction in CVD. So that is not a bad choice. Yes, you could. Remember, Simba 18 we're not meant to be using. And more than 40% is considered the minimum reduction in LDL you're looking for with a statin. So really that's why Atorva 20 and Rasuva 10 are our mainstays. And as you can see here, pravastatin, nice and weak, and yet 20 years of legacy benefit. So improve it. So this is a question about ezetimibe. So improve it was looking at ezetimibe, and as you can see, there is a reduction, but it's small. And this is because on average, you get quite a range of cholesterol reductions, but actually the benefit is related to the LDL reduction. So for people who don't respond to it at all, they don't get the benefit. Whereas if you respond beautifully to ezetimibe, you get lots more benefit. And so it averages out. So I always think it's probably easy just to think it's a bit like doubling a statin. It's definitely good and it will cause benefit, but it's slimmer, which is why we don't use it instead to replace statins. We use it on top usually. Interestingly, if you look at the stroke subgroups, so the hazard ratio for ischemic stroke is 0.76. But if you've already had an ischemic stroke, the number needed to treat to prevent a second ischemic stroke is only 13. So ezetimibe is now off patent, is cheap. It literally has no side effects. So therefore, it's an extremely useful and good drug to add in. So yes, we love statins and we also love ezetimibe. So bomb that one in if the opportunity presents. Just looking at some of the reductions here. So high intensity statin, if someone's got to take it once a day. Cholesterol reduction 40 to 50%, whether you're 20 milligrams or 80 milligrams of your Torva. Lots of CV data, nice long-term thing. I've nicked this from Alison. She might recognise this table. Ezetimibe, once daily, 24% reduction. PCSK9, so subcut injection, 6%, greater than 6%. So, and then also expensive. Bempedoic acid, so I don't know, I mean, what, 30 quid a year, these two? About £1.5 grand a year. Bempedoic acid, about £500 a year. And Inclisiran, about £100 a year. So that's why this one's probably being promoted. So bempedoic acid, 28% reduction, but we have no outcome data. Same for Inclisiran. So Inclisiran is not as effective as PCSK9s and doesn't have outcome data, but it's got much lower threshold. So we actually be able to be, well, there is a large population who we can treat with this, and it's cheap. So there's a new flowchart, but this is all still being debated about what we actually send around to everyone. But they're also going to add it in to a national pathway too. So we should see a lot more guidance. But in primary prevention, basically it's bempedoic acid. You can't use your PCSK9 inhibitors or siRNA. So for primary prevention, forget about the others. You've got statin, ezetimibe, bempedoic acid. The only subgroup otherwise than that is your familial hypercholesterolemia group, who should hopefully get reviewed by us in secondary care. So you can add bempedoic acid in if they're not at target, and as long as they're not on good intensity statins. So here's the national pathway. So you can find it via the AAC or the NHS England. I think on the AAC website you've got the updated one, which includes bempedoic acid. I don't know if NHS England has been updated yet, and I think Inclisiran is going to get put in there as well soon as well. So you've got a pathway to look at, and also wonderfully a statin intolerance pathway, which is also very nice to look at. So statin intolerance is a big problem, and in most cases probably not actually real. It's more about perception. So this is an N of 1 trial, but if anyone's interested reading it, from a New England Journal of Medicine. So basically you had people randomized to the statin, a placebo, or no treatment, and they all had different randomized schedules, and then they had to write down their side effects. and basically it's looking for the nocebo effect. When you talk to people afterwards, and basically you got the same number of side effects in the placebo as the statin group. So just taking a tablet causes a problem. And when you talk to people about it, actually, they were able to get people to maybe think that it probably wasn't the statins. So yeah, scores ranging 0 to 100. So 90% of the symptoms was elicited by the placebo. And actually half of them had agreed to restart statins, 4 were planning to, and 1 was in the wind. 25 wouldn't know, so still convinced side effects. 4 of them, their cholesterol got better, but they did think that they were convinced that maybe it wasn't the statins that had given their side effects. 1 of them was quite convinced that the statins hadn't reduced their cholesterol. 1 of them had, unfortunately, a new diagnosis of a progressive disorder, and someone else thought he was just too old to take them. So it helps in a bit, but as you can see, there still is a bit of resistance to not taking statins, and maybe that's partly in the perception that low cholesterol isn't good for you, whereas actually I would argue that low cholesterol is normal. So you're actually trying to make everyone normal, and I think there's still basically a lot of people are very convinced that they're bad for you, but they're not. Rhabdomyolysis is rare. It's about 1 in 10,000. You expect to see nice high CKs. You want muscle pain and muscle tenderness, so not joint pain. And you want the muscles to be tender to touch. It should be systemic as well. So all muscles, like they've got the flu, and they're really achy in bed. So perishingly rare. I've seen 1. And you have to have rare genetic mutations to be at risk of it. So most people can't even get it. So it really is very rare, and you can use your CK to try and convince people. We've got more and more evidence showing that it really isn't as much of a problem, but on our day-to-day basis, it is a big problem for us. Even in the BMJ this week, they were still saying that LDL reduction isn't necessarily a good thing. It's remarkable the amount of misinformation there is out there about cholesterol reduction. Hopefully, though, now we've got so many other agents, you may be able to try and, if you can convince people that low cholesterol itself is normal and not a problem, then you can perhaps convince them to start on statins in the knowledge that there are various other agents now that people can try to get their cholesterols reduced. And that might give people the feeling that they're not being forced to only take statins, and that hopefully therefore they'll get on with them and not have a problem, because you've got other options. So it isn't the only drug, but in reality it's really effective. You've got the outcome data, and so in our own heads, that should really be our mainstay of cholesterol reduction, because they're great. So when do they come to clinic? So FH genotyping has now become centrally funded, so it's become free, which should really open up the access to genetics. I used to send it, but no one commissioned us to do it, so I used to get told off on a regular basis. So now I don't get told off. Of course, it's still limited by our number of clinic appointments, but they are creating an FH nurse, I think, for our area, but that's only 1, so they'll have a lot of work to do. But if you want genotyping at the moment, you have to come via the lipid clinic. So though it's been commissioned, it has to come via lipid clinics or FH type services. We're the only ones at the moment who can prescribe a PCSK9 inhibitor. So if they meet those eligibility criteria, give us a shout. You may want diagnoses, so you're not really sure what's wrong with them, and you'll want to make sure you're not missing a genetic condition that will have implications for either their management or their families. So besides FH, you might have things like familial chylomicronemia syndrome, which normally you pick up at young ages with high triglycerides and pancreatitis. So high trigs in people at 40 who've never had pancreatitis before isn't the genetic condition, that's alcohol or obesity. Type 3, where they get equimolar cholesterol and triglycerides. But questions about diagnosis you might want to ask us, or then you've got your really special circumstances. You could say intolerance as well, but there are now more options in primary care to deal with those patients. But you may say you've got liver transplant. There are specialist clinics for HIV and lipids, but a lot of these things are getting more straightforward. So it's always worth an ask. But these are the sort of things that we might be able to do that you can't do, but you've got. And now we can't do inclisiran. You've actually got a lot more tools in primary care than we've got now. It's very exciting. Well, I've rushed through that. Questions?
Thank you, Kate. So there are a couple of questions in the box, so maybe we'll start off with those.
Lovely.
So we have I'm just going to scroll down. We have a question here around alcohol.
Yeah.
So it says, I have a few patients who consume excess amounts of alcohol and high cholesterol. Would you recommend a statin, even if Q risk is less than 10%?
Well, the statin won't do much biochemically. So if you're thinking about lifetime cardiovascular risk, then there's no problem with it. And, high lipids and mixed lipids do increase cardiovascular risk. So we may say the Q risk is falsely underestimating their risk. But if you want to make a big difference biochemically, that's when you think about fibrates. And your main reason would be pancreatitis prevention. Of course, pancreatitis can kill you, or render you with pancreatic exocrine insufficiency, diabetes, etc. So it's not a barrel of laughs. So it's quite, that can really weigh you towards a fibrate. Fibrates, though, inhibit creatinine secretion. So just bear in mind the eGFR will drop a little bit, but that's to do with the drug, and the kidneys are absolutely fine. There was also no cardiovascular data to support it, but that's partly because fibrates reduce the triglycerides, which are raised in these sort of metabolic syndromes and alcohol. When they were studying them in cardiovascular patients, they were using people with high LDLs. And therefore, if you don't treat the right people, obviously you won't make a difference. So reducing LDL in people who haven't got a high LDL obviously didn't have cardiovascular benefit. If you look at subgroups of metabolic syndromes and other studies, such as the prevention of and reversal of diabetic retinopathy of fibrates, there is suggestions that there is good cardiovascular benefit in people with high triglycerides. So though it's not in any guidelines, it has actually entered the American guidelines now for diabetics. So for people with diabetes, in the American guidelines, they suggest adding in fibrates if the triglycerides are raised. So fibrates, you could argue, are pancreatitis prevention, but are probably also giving cardiovascular risk reduction, and will have a significantly more larger biochemical effect in that group.
Lovely. Now there's a question about bempedoic acid.
Yeah.
And simvastatin. So you had on your slide simvastatin 40 not to be used with bempedoic acid.
Yes, and I think that's something to do with, was it lactose or something? I can't remember what it said. But yeah, according to the nice tag, it has that underneath in brackets. But quite frankly, I don't think anyone should be using simvastatin anyway. I don't know how many people actually do use simvastatin anymore. I would take the opportunity to move them to atorva and rosuva, which will be much more effective at the same doses.
I think there's an interaction, isn't there, to increase statin levels, so it may well be to do with that.
Maybe, yeah. And certainly Simva is the most sort of side effecty one, so it's not very effective and a bit side effecty. So bomb them all out of Simva. There's one or two people I've met in clinic, but I haven't met them for years, who were convinced that Simva was the only one they could tolerate. But I haven't actually heard anyone say that for years.
There are quite a lot of people out there on simvastatin. I think a lot of it's historical. So I doubt many people are initiating simvastatin these days, but I think there's a lot of historical patients on simvastatin, and I guess part of the statin review could be to make sure that they're getting adequate LDL reduction, and an opportunity at that review to switch them to something that's a bit more potent and has less interactions and possibly better tolerated.
Yeah, definitely. And I suspect you're right, they've stayed, but technically if we're starting statins, if they're on statins, our aim is to get more than 40% reduction, and the only drugs that you can use to do that are atorva 20 or above or rosuva 10 or above. So yeah, if you spot anyone on Simva, swap them.
Lovely. And now there's a sort of question that runs on from that quite nicely. So it says, you mentioned LDL targets, and I think in the lipid world you do tend to talk a lot about LDL, but NICE refers to non-HDL. Can you clarify?
Yeah, so there's reasons why non-HDL were put in, and I think very sensibly they're trying to make people think about cardiovascular risk reduction in a more holistic way. So in your groups of high triglycerides, low HDL, etc., they're at high risk. But if you remember that first case where his total cholesterol is only 5, you just look at the total cholesterol, the LDL's okay, and you're like, well, that's not bad. But actually, if you look at the non-HDL, that's going to be higher because his HDL is low. And the triglycerides, and then it sort of basically takes into context all this sort of metabolic disease, which is a cardiovascular risk factor. So they're trying to stop people only looking at LDL and ignoring the other lipid parts. So as a risk assessment tool, it's probably quite nice. The problem is you've got to look, according to NICE CT 101, for a 40% reduction in non-HDL, which was difficult initially because no one had ever measured non-HDL before. So you couldn't find it in legacy results. You had to calculate it, look at the new result, and then work out if there's a 40% reduction, which again, 40% is not the easiest number to work out in your head. So there's multiple reasons why people haven't really used it. The issue also is that every single trial ever done uses LDL. But as you can see, the fibrate trial, by concentrating on LDL, we missed the opportunity to look at people with metabolic disease and the difference it can make increasing HDL and dropping triglycerides in people with low HDL. So that was the attempt to make people think about it. But in reality, almost all of those drugs, because we're not using fibrates for cardiovascular disease, except maybe, but in all those pathways, you're giving drugs that reduce LDL, and that's the way they work. So it's easier to use LDL because if you look at all the trials, the treatment targets and the treatment success is all based on LDL. None of it's based on non-HDL. So I think it's very important to think about triglycerides and HDL in your risk assessments. But treatment-wise, it remains easier to use LDL. And you do wonder about whether LDL will come back in a bit. And if you see, international European guidance, it's all based on LDLs. And so roughly, secondary prevention, you're looking for an LDL less than 1.8. And then they've got lower targets, so less than 1.4, less than 1. And in my own head, if you've got cardiovascular disease, basically, if I can, I'll give them maximum everything, really wanting everyone to have an LDL of 0. So no LDL, that is where you're actually aiming. For primary prevention, you can be less aggressive. And familial hypercholesterolemia or other genetic risk factors like lipoprotein A, you might want to be more aggressive. You don't want them normal, which is average, it's not normal. You want them normal, properly normal, i.e. if total cholesterol is less than 3, which will be almost impossible to reach often with the drugs that you've got. So yeah, pile them in, everyone.
So I think, Kate, we had a conversation recently, didn't we, about the labs reporting different things. So in Brighton and Hove, we don't get an LDL on our lipid reports, whereas in other areas in Sussex, they do get an LDL. So it's interesting then for people in primary care to be looking at LDL if it's not reported.
Yes, I've asked the Brighton guys if they can add the LDL back in to non-fasting, because as we saw that slide, it's 0.2 of a difference. Do you care? Not really. So we should add the LDL back in. So I think you should get a full lipid profile. We're actually also been fiddling with our local system to introduce a new equation called the Sampson or Ramalais equation, where you can calculate LDL with triglycerides up to about 33. So if you do have someone who also has secondary hypertriglyceridemia, I mean, the party line now is what you really want to do is remove those problems because they're almost always secondary. So if you can improve the diabetes, stop the alcohol, then you'll reduce their risk significantly of all sorts of conditions. And then you can look at the LDL. So treat those other problems first. However, understanding that you're going to have like people with, chronic, poor diabetes control, alcoholics, etc., and you want to be looking at the LDL, and we're going to try and work up an equation where you should get an LDL even when their triglycerides are up. Try and make it easier.
That would be great. And a couple of really practical questions here now. If we're switching people from simvastatin to atorvastatin or rosuvastatin, when and what would you routinely monitor? So when would you do a cholesterol again? When would you do the liver again if it was normal on the previous statin?
Not really, no. So technically, NICE say you do one at 3 months and then yearly. When talking about the previous lipid guidelines a couple of years ago, there was a proposal that whether we just did fire and forget. It's like, why do you ever need to measure it again? Because they work. One reason of measuring it again is if the cholesterol hasn't come down. I mean, it can be non-concordance, of course, but it might be because you've missed hypothyroidism or missed familial hypercholesterolemia or a really high lipoprotein A. So if they haven't responded like you expect, it might give you a clue that you've missed a problem. So it's quite useful just to check that it comes down. But actually, once you've seen someone respond to a statin, you're changing to another, it should all be fine, but technically they say statin 3 months and then yearly. But I think if they've been on statins for years, your risk, your likelihood of a problem is terribly slim, and the liver is idiosyncratic. And why would you do it at 3 months if it's idiosyncratic occur any time in the next 40 years? So the likelihood of you actually missing it, and actually because of that, it probably is just random LFT changes that we're picking up when we happen to do our annual blood screen, not really related to the statin. But a part of the annual screen, of course, for cardiovascular disease is checking they're not smoking, counselling weight, checking blood pressure. So there's other things you're doing at that annual review. But if you're checking if the statin works, they do work, and they're quite predictable. So if you're treating the right people and you haven't missed anything, there's a good debate about what you're actually looking for.
Okay, and then there's another really practical question around maybe using reduced frequency of statins in people that are struggling with statin side effects, perhaps twice weekly, or maybe you could comment on the sorts of strategies you use to help build up doses.
Yeah, and so Rasuva and Atorva have a long half-life, so the sort of minimum effective dose that has, is associated with reduced cardiovascular disease would be something like 5 milligrams of rosuvastatin 3 times a week. But there is really nice data showing that for people who are a bit wary, so you start your Atorva and they don't like it, and you think, right, I'm going to go to Rasuva now because that's nice and effective, and it sounds better because it's half the dose. If you start on 5 milligrams and then let them wean it up, they usually exceed your expectations. So by providing them the power to do it themselves and giving them what sounds like such a low dose so infrequently, they actually usually end on it every day, and often at a higher dose than you would have started, partly because the side effects really aren't at all common. It allows people to feel reassured, and remembering to take things on intermittent days is hard. So it's easier to take it every day. So usually people end up taking them. Many people have ended up on the maximum dose. Well, I've just let them say, here's 5 milligrams, have a go. Off they go. Marvellous. And I think it's just allowing them to take responsibility and check they feel okay. Because everyone has muscle aches and pains and doesn't feel very well, particularly after heart attacks and strokes, where stroke patients often feel terrible for about a year. So it's not surprising they don't feel very well. And to allow them to just do it themselves can mean that you get really excellent, and that's been shown, really good, much better use than you would have done if you just made them take the highest dose.
And presumably there's no evidence data of these small doses just because they've not been used like that in a trial.
Well, we've got doses for like less effective ones. So for smaller reductions in LDL, we know it's linear. So if you're only giving a small reduction in LDL, it's still good. And the long half-life, so we know that alternate days into every other day is enough to get LDL reduction. So yes, so actually, yeah, no, it's fine. But now we've got other stuff to add in. If you add your ezetimibe in and then you add your bempedoic acid in, you may be getting to the sort of cholesterol reductions you would have had with the maximum dose of statin anyway. So yes, all additive. So yes, it's fine.
Okay, probably got time for 2 more. So here's an interesting one. If inclisiran is so cheap, and it's fulfills the criteria, if the LDL is greater than 2.6, why don't we just go straight to that and ignore everything else?
Yes, it's a good question, mainly because of the decades data of safety and cardiovascular outcomes. There's no cardiovascular outcome trials for inclisiran. There will be increased cost for you because you've got to do it. So that's nursing, appointments, letters, etc. So the drug might be cheap. But then, of course, you've got balance with the prescriptions for statins anyway. But, there's this intervention of injections. So there's no outcome data. Also, it's an siRNA, which I don't know if anyone's ever used an siRNA before. I think there's one drug on the market, but it's not really widely used. I think it was taken off maybe. So no one really has ever used this type of technology before. So I suppose the question is, do we know that it's going to be? So we think LDL reduction should be safe and PCSK9 obliteration is also good. But is there another problem that we don't know about siRNAs? The RNA vaccines cause a great furore, but this one, straight in, no problem. So it's interesting. So it should be fine, but we don't know it's fine. So we'd definitely do statins first.
Excellent. Are the cardiologists right in putting every patient with an MI on atorvastatin 80 milligrams, even if they're 80 years old?
Yes, big time. So the reduction in cardiovascular disease occurs within 6 weeks. So the question is, are you is someone aiming to increase their life expectancy or not? So if they're periterminal, you know, with metastatic cancer, etc., yeah, fine. No, don't bother. But otherwise, we're like practicing age discrimination. And we know that some of our 80-year-olds are so fit and healthy, they will do to 100. So if they then have a stroke and are hemiplegic for 20 years in a nursing home, that's extremely expensive. So if they're fit, well, independent, etc., then preventing these events is extremely cost effective, even at these older ages, because people live so long. So we'd prefer people to be fit and well, and then when they have a vascular event, to die, but much later. So that's fine. But we don't want the morbidity from the heart failure and the stroke, and neither do the patients. So yes, if the 80-year-old's, you know, fit and well for an 80-year-old, bang in the statins, because they're extremely cheap, effective, and they work very quickly. But if you're stopping in 80-year-olds, you won't get any loss of quality of life. So there's no change in symptoms. So you won't make anyone feel better. But if you're going around and reducing drugs in a palliative care setting, you can reduce the statins. It won't make them feel better, but that's absolutely fine. And the legacy benefit for someone who's been on it a long time will be enormous. But you're right, in comparison to a 12 or 20, it's also only made a 10% difference, but 10% still counts, does still have reduction in risk.
Fabulous. So I think I'll squeeze this one in. So Dutch Lipid Clinic criteria for FH, a score of 4, no tendon xanthoma or arcus, no family history, cholesterol 8.8, LDL 5.88. Are you interested in those for your lipid clinic in terms of screening, or would that not fit your criteria?
So it's a good question. So when they've just got a high cholesterol, sometimes people write to me. Occasionally I see people, it's usually when they don't know their family at all, so they're adopted. But if they know their family and absolutely no one's had any cardiovascular disease, particularly if they're older adults, then I'd be less worried. I'd look at the triglycerides as well, because if the triglycerides are up as well, I'd be much more relaxed. It doesn't necessarily mean it's good for them, but it just means less likely that I think it's familial hypercholesterolemia. Postmenopausal hypercholesterolemia is fiendishly common. Women are 9, 10 total cholesterols, so that is not that infrequent. And of course, we haven't measured their cholesterols often before, so we don't know what it was premenopausally, but it was probably fine. So it depends how reassuring the rest of it is. Lipoprotein A can up your cholesterol a little bit, so you could look at lipoprotein A and just see if it's not that genetic condition. If they're very young, you'd be a bit suspicious, and I have seen in clinic a de novo mutation. So that was a young girl given Roaccutane, and instead, you check the lipids because the triglycerides go up. Her cholesterol was 18. They were like, oh, that's a bit strange. So they took her off Roaccutane. It did come down, but it didn't come down to normal. So she came to lipid clinic, and she's a de novo mutation. So though I said we found 2,000 mutations, we think we found most of them. Her mutation is one that has never been described before, and neither parent had it. So either it's non-paternity, but we didn't go down that line. We said it's new. So she's probably got a germline mutation. So she has brand new FH of a mutation never described before, picked up by Roaccutane lipid screening. So yes, it's possible that person could be a new mutation, which was why there's no family history. But it's just look at how old they are. Do you have any early lipids? If you've got early lipids that are normal, I'm not worried. It's probably just age increases, menopause, for example.
Wow. Thank you so much, Kate. There was a lot of questions there. I hope people found that really helpful and interesting. Thank you for your time, your expertise, for sharing your slides, and for answering all the questions while we put you on the hot spot.
Pleasure.
Thank you very much, everyone, for joining us, and hopefully we'll be back soon with another session for you.
Thank you. Bye.
Bye-bye.